In this time, so many things are changing and revenue is certainly not an exception. This morning, we have HRG Executive Director of CBO Services, Cassie Wise, joining us to discuss the best ways to navigate the revenue fluctuation storm. Go ahead and take it away, Cassie.
Perfect. Good morning, everybody. I have a housekeeping item as well. I don't think my twins are awake yet, but if they do happen to wake up, you may hear them in the background running around. So my husband has been tasked with keeping them quiet, but we'll see if he accomplishes that goal or not. I too wanted to thank everybody for coming out this morning to join us to talk about revenue fluctuation. We'll go through a lot of scenarios that we're seeing across the nation right now and give you some insight into some different ways that you can look at your AR to really gauge how well you're doing, because as we know, revenue can affect everything in your AR. So with that, we'll get started. All right, so I just wanted to start out by talking about some current revenue cycle trends across America. As you all know, the COVID-19 pandemic is putting pressure on hospitals and health systems across the U.S. There's no guesswork happening there. It's definitely happening. So I wanted to go through what is happening in each of the different facility types. And so the first one I'm going to talk about here is urban hospitals. So what urban hospitals are seeing is vastly different from what you were seeing happening in the critical access and rural health spectrum. Urban hospitals are seeing patients that used to look like this now looking like this. They're being overran by the critically ill, people who are requiring vents, and they are being forced really to provide treatment that is skyrocketing. Oh gosh, slides are getting a little crazy here. It just doesn't want to stay on that one. So we're seeing skyrocketing treatment expenses. So they're seeing patients that, up until this point, there really wasn't a good DRG for COVID-19. And so the reimbursement that these urban hospitals are getting are not anything near what it's costing them to treat these patients. And so they're losing revenue in a different way. They're losing it on the cash side. It's costing them a lot of money to treat these patients, and they're not getting the reimbursement needed to keep everything afloat. They're facing staffing challenges. They're facing fears of bed shortages. When you've got your hospital overran by patients coming in, there's a fear of bed shortages happening as well. And then on the flip side of that, their bread and butter, what they used to get all their revenue from, was canceled. So there's no procedures happening. So really, it's a perfect storm of not a good revenue or cash collection picture for those urban hospitals. There's also seeing increasing uncompensated care due to loss of employment. So patients no longer have employer-sponsored insurance in a lot of cases, especially those in the entertainment industry and in food service. And so they no longer have insurance, which means that when they come in, they do not even have insurance to process these claims. On the critical access side, even before COVID-19, critical access hospitals were facing a lot of financial challenges. While rural hospitals are not being hit as hard with the COVID cases, they've lost, again, their bread and butter, their procedures, their colonoscopies, their tonsillectomies, their common procedures that were happening, and their patient base now looks like this. So on average, critical access hospitals have lost about 25% of their monthly revenue due to this reduction in cancellation of elective procedures, but then also patients avoiding outpatient treatment because they're in fear that they're going to contract COVID. So again, twofold, they're losing revenue. Different than the urban hospitals, but very similar in that revenue is gone. They're also seeing an increase in uncompensated care due to loss of employment, just like those urban hospitals. The physician practices, however, their patient base that used to look like this is now looking like this. Because many Americans have foregone care, including their primary care and other specialty visits. A lot of providers have raised concerns because they're concerned that people are not receiving chronic disease management and other important care, which in the end is going to land these people in a more stringent health situation where they're in the ER, potentially in the ICU, because they're not getting that preventative treatment that's necessary. So they're seeing loss of revenue from patients avoiding outpatient care. There's a very stark increase in telehealth visits across the nation, which means that patients have options. They can see patients in Cincinnati rather than their local provider by calling the telehealth number on their health insurance card. And so they're seeing a loss of revenue due to that as well. There also, there wasn't a way till recently for those rural healthcare providers to provide telehealth services. Now with COVID they can, but still uncharted territory, and still trying to work through that. And then they're also seeing an increase in uncompensated care due to the loss of employment for their patients. So I just wanted to talk quickly about some of the key trends that we just went over. So the American Hospital Association has reported that revenue has decreased a staggering 34.5% across the nation. So where I mentioned earlier that critical access hospitals were seeing a 25% decrease, in our complete business office clients that we have, when I look across the board, we were seeing about a 25% decrease, where nationwide it's upwards of 35%. It has been estimated that hospitals are losing an estimated $50 billion a day in revenue. So it's across the nation, $50 billion. Some hospitals are being flooded with costly patients, while others are losing patient revenue. An estimated 27 million Americans may lose their employer-sponsored health insurance due to job loss. So according to a Pew Research, unemployment has gone from 3.8% to 13%. And the American Hospital Association also is already reporting a 13% increase in bad debt due to COVID. So we're seeing a lot more of that uncompensated care come through. Patients are avoiding care, which we've already talked about, which could lead to illness. And then our ER, outpatient, and urgent care services are down, while telehealth has increased rapidly. So when you look at charts across the nation, you're seeing that those three service types are reducing and that telehealth has increased rapidly. What we don't know at this point is if those telehealth visits are replacing those ER and urgent care visits, or if patients staying home and not being out in the public as much is reducing the need for the ER and urgent care. Those statistics aren't in, so we don't know if it's a one-for-one or if people are choosing telehealth in lieu of going to the ER. So for the rest of the presentation, we're going to focus on the revenue side of it. So healthcare is facing a plethora of issues due to COVID, but we're going to talk about just the revenue piece of this. All right. So our first, and we're going to go through about 7 AR metrics and to talk about what we can do to be proactive, and then on the reactive side, a couple of metrics as well that we can look at maybe a little differently than we typically do to really identify what's happening with your AR. So the first one I'm going to talk about is revenue. So this whole presentation is about revenue. So revenue, the objective of revenue monitoring is that it's our best indicator on what's going to happen to the future of our AR. This graph here gives you an example of what an average hospital's revenue looks like. So we have this kind of horseshoe that happens between March and July. What happens because of that, and we'll see it in a few slides down, is that everybody's AR days shot through the roof. So I wanted to explain a little bit about why that happened, and then if this ever happens again, or if you ever see a revenue downtrend in your facility, what you can do to potentially explain to either your CEO or your CFO or your board of directors what's really happening to ease the concern. Because when you're looking at AR days only, it doesn't give you a complete picture of what's happening. So what you can expect when revenue decreases is that in the next 30 to 45 days, you're going to see cash do the same thing. So this is your best indicator into what potentially is going to happen in the next 30 to 45 days. So it's really important if you do start to see a revenue downtrend, that you start doing everything you can to get in every single dollar you can. And I know that on a daily basis, that's what everyone's goal is. But it's time to maybe switch gears and focus in some other areas to try and compensate for some of the cash reduction that you're likely going to see in the next 30 to 45 days. The next one, our metric that we'd like to look at is unbilled. So unbilled is cash just waiting to be in the bank. So I joke about it being like Pinocchio. He just wanted to be a real boy. These accounts just want to be cash in your bank. And so monitoring the unbilled is key to making sure that your cash is as stable as possible. And it's important to look at unbilled not just in the DNFB or the stuff that's waiting to be coded. You can find unbilled money laying in a patient bed. If you've got the option to bill for cycle services, bill the cycle services so you can get those cash in quicker rather than waiting for the patient to be discharged. You may see your unbilled sitting on a doctor's desk waiting to be signed. So make sure that you're uncovering every area that you can reduce that unbilled. I always laugh at this one. The sun never sets on an unbilled claim. This is one of our consultants that I worked with for years used to say this all the time. The sun never sets on the unbilled claim, and so I just wanted to throw it in here. Unbilled claims are like Pinocchio. They want to be real cash, and the sun never sets on them. The next one is claim submissions. So claim submissions are your best indicator of what you can expect in cash collections moving forward. So revenue gives you an idea of what's going to happen. That's if all the cash or if all of the claims get submitted. Claim submissions they're out the door. They're with the payers. So this is really your best indicator of what you can expect in the future as far as cash goes. You always want to make sure that your claim submissions are at minimum what you're seeing in revenue each week. So if you're seeing a revenue reduction, you're likely going to see a claim submission reduction, but you never want it to drop lower than what you're seeing in revenue being put on the books each week, because that means you're getting behind the ball a little bit there. So some things that I track when I'm looking at claim submissions are, I'll throw a little clean claims right in here, is what claims were uploaded into your scrubber, both dollar and counts. And then because you're in there, you might as well grab what was clean versus dirty so that you can keep track of what's happening as far as edits go and if there's things you need to fix upstream a little bit. The claim submitted to information that you need is the dollar amount, who the payer was, and what the date of service is. If you want to get really technical, you can throw in some of the patient type information, which could potentially help you with the next slide, which is cash projections that we're going to talk about. But just make sure that your claim submissions, like I said, are above what your revenue is trending at to make sure you're not getting behind the ball there. So cash projections. So the objective of cash projections is to take those claim submissions that were sent out and obtain an estimated cash and when you can expect it. So it's one thing to say I had $500,000 in revenue that I billed out last week, and so I'm expecting $250,000 from that. Not all payers pay at the same time. So by taking that data that we just talked about, the payer, the time for that payer to pay, and then your estimated your collection percent on average that you have for each of those payers, you can get an expected cash and then when you expect that payment to come in, which will give you some pretty good cash projections. Because, for example, Medicare, when you send those out, we're going to get them paid in 2 to 3 weeks, where Blue Cross may take a little bit longer or commercials may take a little bit longer. So you don't want to project all of that cash at the same time just because you sent it out this week. So what you want to do is separate each week's claims by payers, multiply the claim submission amount by the average collection percent for each payer to come up with your expected payment amount. You then review the previous payments for each payer to identify the payer time to pay. So how long on average is it taking those payers to pay? And then utilize that time to pay to identify which week you can expect payment from the claim submitted. So I just do the calculations down below, but your expected cash and then your expected payment date for each payer will give you a really good idea of what you can expect in weekly cash in the coming weeks. This also is going to be a really good indicator for you especially even if revenue is down, when you're going to start seeing that cash decrease. And if there's anything we can do right now to help us out in 3, 4, and 5 weeks from now to help stabilize that cash. Cash collections. With cash collections, you want to monitor what was expected based on the projections that we just talked about and compare what you actually collected. If cash is lower than you expected, you want to identify which payers have come in shorter than you expected. And because you have that clean detail from the cash projections that we just talked about, you can pull a sampling of those claims that were expected to pay and see what's happening with them. Is it the payer is taking longer to pay and we need to adjust our projection timeline for time to pay? Are we seeing a lot of denials for some reason? We've got a lot of new COVID claims going out and they're not processing as they should. And then another place you can look at is denials. Look at what denials are that you're receiving and see how much of that is being affected or throwing off your cash projections as well, or your collection versus projection. The next one I want to talk about is accounts receivable balance and AR days. So your accounts receivable balance and your AR days are they don't necessarily work in the same manner. Your AR can go down, but your days can go up in some situations. Accounts receivable AR days were designed to produce a number that can be described as the average number of days between when charges are booked and when payment is received. And so it's something that every CFO looks at, a lot of boards look at them, and it's kind of the holy grail of the health of your AR. Unfortunately, when revenue is fluctuating greater than 10%, those days are thrown off because AR days are taking an average of the last 3 months revenue. It can throw off your average daily revenue and cause those days to increase even if things really are headed in the right direction. So for those of you who don't know how to calculate an AR day or want a little bit of a refresher, what you do is you take your gross revenue, and not every AR day is created equal. Some facilities do a 6-month rolling, some do a 3-month rolling, some look at net, some look at gross, some throw out self-pay. So if someone tells you that their AR days are 28, don't take it at face value. Because they're likely not calculating gross. They're likely, and they may be a clinic. Clinic is different than hospital. So just don't take AR days at face value. Make sure that you understand the calculations behind it, because they get thrown around a lot, and I think they lead people to feel like they're not performing well when it may be a case of they're talking about net AR days instead of gross, that sort of thing. So in this example, I took this, it's kind of industry best practice or pretty standard to take your gross revenue for the last 3 months and divide it by the number of days in those 3 months to come up with your average daily revenue. You then take that average daily revenue and divide it into the gross AR to come up with your AR days. All right, so let's look at a couple of examples of what can happen when your revenue fluctuates less than 10%. If you look at that top chart there, this is an example of when revenue is not fluctuating heavily. And for these examples, just so everyone's aware, I took the gross revenue and the AR balance and I kept them the same. So theoretically, these examples should both be very, very, very clean AR day figures because we don't have any more money on the books than we had in revenue booked the previous month or during that month. So you can see in that top chart where the revenue has fluctuated less than 10%. You see that the AR days do the same. They fluctuate less than 2 to 3 days. Everything looks pretty good. When you get down to the example of greater than 10% fluctuation, you can see, and again, I left the gross revenue and the gross AR the same, meaning that my AR is very, very clean. I've got no more on the books than I put on in revenue that month. But when your revenue fluctuates, you can see in the month of March that we had 30 days in AR, but when revenue dropped to 150, and this is very similar to what a lot of hospitals saw, you see that horseshoe shape in that graph down there in the bottom left. That's a representation of both of these charts where it shows you what revenue looks like. So when you look at the month of March, everything looks good. In April, our revenue drops, but so do our days. So things just look really good. But then we start seeing that revenue it drops a little bit further in May, but then it starts to go up in June. So in June, if we look at it, their days went up to 31.7. But again, their gross revenue and their gross AR is the exact same figure. But we've seen a swing between May and June of 7, almost 8 days in AR. And then in July, even worse. So in July, their revenue got back up to the same level as it was previously, and we saw a spike again of 7 days. So it appears by looking at AR days alone that that your days are just going through the roof and your AR is out of control. When the reality is behind it, if you're looking at your revenue and your AR, you're just as clean as you were 6 months prior. It's just the nature of the way the AR days work. The graph on the bottom right-hand side gives you just an example of the 10% fluctuation versus the greater than 10% fluctuation. Again, so you can see that yellow line where we've got a greater than 10% fluctuation, you just start seeing your days go through the roof. But when you see the figures behind it up above, you can see that the AR is really not in that bad of shape. It's in just as good a shape as it was months prior. All right, so what do you do when that happens? So when revenue is not stable and it throws your AR days off, I use this alternative method to calculate what I call the delta difference between your revenue and AR. So what I look at is the gross AR and the revenue. So if we take a look at our gross AR, our AR went up in this example. It went from 135 to 175, which is a $40 decrease from June to July. And then I took a look at the revenue, and I can see that revenue went up $50. So if you take that gross AR increase of $40 and take out the revenue increase of $50, your delta difference is that you actually made a 10% improvement in your AR. So the purpose of this calculation is really to remove the fluctuation in revenue from the gross AR and identify if the AR is moving in the appropriate direction. Is my team making progress? And so by doing this calculation, you're able to remove that fluctuation in revenue out of the picture. You're basically taking care of that revenue fluctuation. So in this sample, the revenue grew, but the AR closed with an increase. So revenue grew 50, AR only grew 40, which means that on a month-to-month basis, you can expect your AR to change or fluctuate about as much as your revenue is fluctuating. So in this case, it didn't fluctuate quite as much. It didn't go up about $10,000 like we are $10 as much as we would have expected with that revenue increase of 50. So this is an example, or this is the actual graph of the previous slide, where you can see that you have a $50 increase in revenue and a $40 increase in AR. So our delta difference is we cleaned $10 more off of the AR than we anticipated. And I threw the AR days down here in the bottom of that graph to give you an idea of what the days in AR did. So even though we cleaned more off of the AR than we had a revenue increase, our days in AR still went up by 5 days. So it's really important to be able to tell the story behind the AR days. So in this example, revenue was reduced substantially, greater than 10% over the course of 3 months, but has rebounded. So we actually are seeing a lot of positives here. We're seeing revenues back up, which means we're going to have more cash in the next couple of months. We're seeing that we cleaned more off of the AR than we had an increase in revenue the previous month. All of these are really good stories to tell, but if you're looking at only the AR days, it's looking like you're performing very poorly. This scenario right here is very, very, very similar to the hospitals across America. I can tell you when I reviewed about 25 different scenarios over the last 6 months, I saw an average increase of between 5 and 10 days in AR due to this scenario. We saw that dip in revenue, and then it came back up, and our days in AR just looked like junk. However, our aging looked great, or looked terrible. So we'll talk about aging now. So our objective around looking at accounts receivable aging is that it gives you a snapshot of the revenue that is outstanding past a certain age. So this metric is used to identify when there are billing or collecting issues. The calculation on this one is just your aged AR balance over a given time period. So typically we look at everything that's aged over 90 days. You may look at a different figure. Again, when someone, age is not created equal. Someone may be looking at aging over 120 days or over 180 days. So make sure you understand the calculation behind whatever figure it is that someone's telling you their aging is at. So your the overall AR over 90 days divided by the gross AR gives you that aging percent. No, again, this works well when revenue on average fluctuates less than 10%. So your example on this one, and I know that we're running out of time, so I'll try to hurry here. The example on this one is on the top where you have that less than 10% fluctuation. You can see, and again, I left the gross AR and the gross revenue exactly the same. In this case, I also left your aged over 90 exactly the same. So I didn't change it across the board. So you can see what happens when revenue is stable. If aging stays exactly the same, it doesn't get any worse, doesn't get any better. You see a fluctuation of less than 3% on this, 2% actually. But when you look at your example of greater than 10% revenue fluctuation, so again, I left the aged AR amount the same across the board. I also left the revenue and gross AR the same, but this time I put that revenue dip in there. And you can see a swing happen in your aged over 90 by about 8%. So the key takeaways on this one is look at the dollars in your aged over 90 in conjunction with your percent over 90, because that percentage may not be giving you an accurate picture of how you're actually performing. So it's important to note too that sharp revenue fluctuations will not affect your aged AR or your AR over 90 days for about 90 days, obviously. Revenue has gone down this month. It's not going to flow over into your aged over 90 for 90 days. And so you can't expect to see a sharp or a stark decrease in your aged over 90 at the same time that you're seeing a stark decrease in your revenue. Obviously, if you focus your staff there because you've got less upfront work, then you could start seeing that reduction. But it typically is not going to happen within the same month. So just keep that in mind. All right. So in closing, to stay ahead of your revenue fluctuation waves, monitor these metrics weekly. So we talked about revenue, unbilled, claim submissions, cash projections, cash collections, and then on a weekly basis, it's easier to look at your accounts receivable balance than it is your AR days. I typically look at balance throughout the month and look at the AR days at the end of the month. And with revenue, I just look at month to date when I'm looking at my weekly metrics. And then look at your accounts receivable aging too. It's going to help you stay ahead of what you can expect when those month-end reports come at the end of the month. All right. Every good presentation ends with a quote. So I found this one here that I felt matched beautifully. And that's, "A smooth sea has never made a skillful sailor," by Franklin Delano Roosevelt. And that's it. So if you have any questions, Taylor will take it from here.
Awesome. Thanks, Cassie. Great job. As usual, you guys, we will be sharing the webinar recording and slides in an email later this afternoon. Included that email is a link to a survey. We would so appreciate you guys letting us know your thoughts on these webinars. We have been taking these responses super seriously and incorporating as many topics and recommendations into our lineup as we can. Additionally, in that, you can request a certificate of attendance, and upon the completion of the survey, you'll be entered to win a $25 Amazon gift card. As I mentioned earlier, following this week's webinar, we'll be taking a break for the rest of this month and returning with new webinars in September. In the meantime, be sure to check out other great free resources from HRG, including our library of webinars, podcasts, and blog posts. Thank you all again for joining us. We look forward to being back with you next month. Have a great rest of your day.